Fluid and electrolytes. Introduction. Total body water is 60% of the body weight in males and 50% of the body weight in females. That is 30 liters totally. Extracellular water is 10 liters and intracellular water is 20 liters. Extracellular fluid volume and osmolality is controlled by aldosterone, ADH, that is antidiuretic hormone, atrial natriuretic hormone. Water loss. It is the decrease in the whole body fluid volume. In this, there are three types: isotonic volume depletion, hypovolemia, only pure water loss. First one is isotonic volume depletion. Here, fluid loss is only of extracellular fluid. Normal or decreased sodium is observed. This causes hypotension and decreased tissue perfusion. Signs and symptoms are dry tongue, rapid pulse, cold clammy extremities, sunken eyes, hypotension, oliguria, raised blood urea, decreased urinary sodium. Hypovolemia can be mild, moderate or severe. Only pure water loss occurs due to poor fluid intake or diabetes insipidus. It causes dehydration with proportionate decrease in the total body water. Signs and symptoms are severe thirst, confusion and convulsions due to hyponatremia, mild dehydration, normal blood pressure. Management: isotonic volume depletion, 0.9% of normal saline infusion. In case of pure water depletion, more water intake, IV 5% dextrose infusion. Monitoring the fluid therapy by skin and tongue examination, weight gain, pulse and blood pressure. Water excess or extracellular fluid volume excess. It can be divided into water and salt excess or purely water excess, which can be called as water intoxication. Water and salt excess occurs in congestive cardiac failure, cirrhosis of the liver, nephritic syndrome, hypoproteinemia, renal failure, excessive saline infusion. Second one is water intoxication, occurs in TURP. TURP means transurethral resection of prostate. Excess infusion of 5% dextrose only, SIGADH, that is syndrome of inappropriate antidiuretic hormone. Psychogenic polydipsia. Causes are excessive amount of intravenous 5% dextrose infusion during colorectal bowel wash, in TURP, again in syndrome of antidiuretic hormone, which is associated with lobar pneumonia, emphysema and head injury. Clinical features are drowsiness, weakness, convulsions and coma, nausea and vomiting, passage of dilute urine, distended neck veins, pedal edema, gain in body weight, bilateral crepitations and ascites. Circulatory overload can be observed. Investigations are hematocrit and sodium level observing, low potassium, low blood urea. Treatment: water and salt restriction and observation, monitoring in ICU, management of fluid and electrolyte balance, infusion of hypotonic sodium chloride. Extracellular fluid loss. Here only extracellular fluid loss is present with normal intracellular fluid. It is seen in vomiting, diarrhea and intestinal obstruction. Treatment is infusion of normal saline. Extracellular fluid excess. Only extracellular fluid excess without an intracellular fluid excess. Excessive infusion of saline with impaired excretion. Raised JVP, cardiac failure and peripheral edema. Treatment is fluid restriction and diuretics like furosemide. Hyponatremia. Decreased sodium level in the body is called as hyponatremia, that is less than 130 milliequivalents per liter. Types: acute hyponatremia, chronic hyponatremia. Again, subtypes are hypovolemic hyponatremia, hypervolemic hyponatremia, normovolemic hyponatremia, and pseudohyponatremia. Acute hyponatremia. Sodium level is lesser than 100 milliequivalents per liter. It presents as neurological manifestations. Chronic hyponatremia. Sodium level is lesser than 150 milliequivalents per liter. Causes: pontine myelinolysis. It presents as a behavioral changes, progressive weakness, and cranial nerve palsies. Hypervolemic hyponatremia. In this condition, rapid absorption of fluid occurs into the intravascular compartments, leading to pulmonary and cerebral edema. It is due to decreased osmolality, causing the movement of extracellular fluid into the cells. Serum sodium level is less than 100 millimoles per liter is called severe hyponatremia, which causes convulsions. Here, urine sodium level will be less than 15 millimoles per liter. Treatment for hypervolemic hyponatremia: fluid restriction, hypertonic saline infusion, administration of loop diuretics like furosemide. Correction of sodium levels should be slow and gradual, that is at a rate of 2 milliequivalents per liter per hour, with up to 20 milliequivalents per liter in 24 hours. Every fourth hourly assessment should be done. Rapid correction can lead to irreversible myelinolysis of pontine. Hypovolemic hyponatremia. Causes are vomiting, diarrhea. Here, urine sodium level is less than 20 millimoles per liter. If it is caused due to diuretics or renal pathology, urine sodium level is more than 20 millimoles per liter. It might be caused due to correction of hypovolemia by using hypotonic fluids like 5% of dextrose. Treatment is infusion of isotonic normal saline. Normovolemic hyponatremia. It may be due to renal failure or syndrome of inappropriate ADH. Secretion. In mild asymptomatic patients, it is corrected by fluid restriction, vasopressin antagonist, democycline, which increases the diluting ability of the kidney, is used in severe cases. Pseudohypoproteinemia, pseudohyponatremia. Plasma osmolality is mainly achieved by serum sodium, but small proportion, that is 25% of osmolality, is due to other solutes like glucose, lipids, plasma proteins, urea, which will not move easily between the intercellular and extracellular spaces. When concentration of these molecules rise due to some pathology, proportionately relative concentration of sodium will drop, causing pseudohyponatremia. Here, condition causing related to specific solutes mentioned above is treated than the hyponatremia. Causes of hyponatremia are intestinal obstruction, intestinal fistulas, that is biliary, duodenal, pancreatic, and gastric fistulas. Gastric outlet obstruction with severe vomiting, Rayleigh tube aspiration, severe diarrhea due to viral cause in colitis, colorectal polyps. Syndrome of inappropriate antidiuretic hormone immediately after the surgery and trauma, stroke. Clinical features are dry coated tongue, sunken eyes, dry wrinkled skin, hypotension, dark scanty urine, irritability, disorientation, neurological manifestations, convulsions. In chronic hyponatremia, hypothermia, reduced tendon reflexes, and pseudobulbar palsy can be observed. Investigations are serum electrolytes. In that, urine sodium is low. Sodium deficit is calculated by 125 minus present serum sodium into body weight in kgs into 0.6. Treatment: intravenous infusion of normal saline in slow and gradual manner. Hypertonic saline of 1.6% or 0.3% can be used in severe cases.